if you've seen one medical respite program, you've seen one medical respite program. Same with health homes. I think that's why our moderator and Shani wanted to show you the breadth, is if you've seen one health home, you've seen one health home. So I'm going to spend a little bit of time talking about CBC as a health home, and then talk about how we as an entity are sort of looking beyond. And I may skim over our case study, although it's very lovely. I think we have a really rich experience. CBC was created by many of New York City's providers who wanted a stake in the changing landscape of healthcare, and wanted to continue to serve the folks that were most at risk, and be available for the opportunities under Medicaid redesign. Our health home is our first product. CBC plans to be at the forefront of this change through time. We became a health home as a lead in Brooklyn, Manhattan, and we are the only designated lead in Staten Island. We're also a partner with the Bronx Lebanon Health Home. This number is growing every day, but CBC as an entity has 56 members. We have in our health home over 115 network partners, but the unique portion of the health home can be catered to a person's unique needs. Our network is pretty expansive. 32 agencies provide care management, and these are converting targeted case management, CIDP, MATs, and COBRA programs. We have 100 comprehensive medical clinics, 100 licensed mental health clinics, a continuum of other mental health programs, PROs, ACT, clubhouses, substance abuse treatment providers, and an estimated 20,000 shelter and supported housing bed with supported services. We're a little bit of a beast in New York City down. We emerged. The reason we are strong is that we were built from we are on the shoulders of a fantastic provider network. Our origins were in case management and community work. 27 of the 32 providers have been doing this and been doing it well for years. We developed a program manual, bless you, that took in those lessons learned. And then 5 of those providers were doing had additional expertise in street outreach and shelter operations. We are built, again, from the belief that we don't want to reinvent wheels and good care and practices that work. We want to get people together to share the practices that work and innovate to promulgate successes from future collaborations. We are building our health home model of care. As you can see, it comes out of 4 major areas, and the last, we always add in that area of, all right, then what's next? You have a group of individuals who have to identify ways of working with a caseload that may be higher than one worked when they were in targeted case management. You have to figure out on a percentage dollar as a health home to be able to provide training. You have to be able to figure out with a caseload what are the interventions that go along with each. So we're building that, and then we're always asking the question, what else? What else can we learn? What's next? What are ways we can be better? Really quick, this number always changes too. To date, we have processed over 28,000 referrals. Those are unique individual people, names who need our services, and of that amount, we are currently serving 11,644 across the 5 boroughs. Half of them are either in outreach or enrolled, or just assigned. I always leave the caveat of the patient tracking system, but unless you're in the health home world, you may not understand the mire of that. So we as an entity are trying to continue the flavor and the wonderfulness of partnerships. So we are positioning ourselves for DISRIPs. We're preparing for HARPs. we as an entity are also creating an IPA to be able to continue for providing a quality network of services for Medicaid recipients with serious behavioral disorders. All right, so I'm going to talk about one of our strategic partnerships, because we just don't say, what are we going to do? We go big. We say, well, we would like, we have had partnerships in different ways with the Department of Homeless Services, and the Department of Homeless Services has these opportunities to, that they have a need to house. We have a need to get people into housing, because we know people who are stably housed have better health outcomes. They commit less crimes. They are happier in their communities, and they feel more empowered about their care to make better choices. So DHS, greatly enough, actually met with all of the health homes in New York City in the fall of 2013. They asked all New York City health homes if a further partnership was wanted, and we all absolutely grasped that, would love that. They asked each shelter which health home they wanted to be paired with, and CBC came up 43 out of the 99 shelters in New York City. That was a little overwhelming for us. DHS also took on the very heavy weight of explaining health homes to their staff, to all of their 99 shelters. We maintained, throughout this contact, we actually maintained a day-to-day contact with a shelter administrator to make sure that this relationship was sustainable. Since then, we actually were able to accept the partnership of 31 of those shelters, but of the 31, only 11 of our care management agencies actually could directly partner with a shelter. Those of you who are, I have a feeling that when you were answering, you're raising your hand, affiliated with a health home, affiliated with housing, that you may have been both, because we often work for agencies who are invested in both. So 11, so my point being is that agencies are taking on a lot, and sometimes innovative partnerships, the ROI on that investment on patient care, on whether or not you can allow a staff member to invest in a partnership that may not yield more enrollments, is difficult. That unknown is difficult. So 11 of our agencies were able to be paired. Since we started in January, and so far 331 people have been enrolled through this partnership. Of those 331, 42 have gone on to move into more supported housing. There's a difference in partnerships across the shelters. We've had folks who have had great interactions, and I'm going to quickly go over the lessons learned from that. We've had one agency enroll over 100 individuals and another enroll none. So quickly, the lessons learned is that it's all about the relationship. I think we could probably put that as a lesson with all of our presentations. But some concrete things is that right away, we need to understand as a health home that, and I appreciate Kristin always going over what is a health home, because even though we have been doing this roughly for 2 years, we still have to walk into a conversation owning that we may have to explain the health home is not a place, the health home is a network, that conversation. So our care management agency needed to walk in expecting that, and not walk into expecting a shelter to be an expert on a program that is still, evolving. So the partnership was very important. We found that some concrete lessons, having the housing intake coordinator and the health home staff meet with the client was very helpful. Scheduling a very specific day and time to meet with potential member was very helpful. Also utilizing vacancy report internet searches, and working collaboratively to work through the housing application. Another important thing is that using an adapted form of an evidence-based practice. This idea of if a health home care manager can spend a lot of time with that person while he or she is still a resident of the shelter, when they go and move into more supported housing, that relationship will be strengthened enough to where they can then build their community and network around their new place of living. So some lessons learned about making sure everyone was on the same page about the MRT beds. We're actually in the process of developing a workflow, and this may seem very straightforward, but we found that we as a health home are learning too. We want to be able to provide support for our care management agencies. This partnership was so new, the care management agencies had to learn this along the way. So we're trying to codify, concretize, and then share what's worked so far. So these are some workflows we're working with. The ideas we're having for innovations in ways of engaging folks who are either so connected to disjointed systems of care or not connecting at all. The partnerships on multiple levels with city offices, plans, and hospitals, and not forgetting about the engaging folks in technologies in a way that meets their needs. We need to look further into cross-sectioning data to provide the best care across cultures, and not forget that while we are really good at providing social services, we at CBC anyway, we're trying to have more of a presence on social media, and we realize that none of us really do, and we actually we need help on Twitter. I think we're at a place where having multiple ways of communicating and having the awareness that people are going to communicate in multiple and different ways, we need to get on board.